Hello everyone, my name is Helen Goldie. I'm a clinical pharmacist at Great Western Medical Practice as part of the One Medical Group, and I have a special interest in menopause. So tonight I'm going to talk you through all the different types of HRT that there are available, the pros and cons of using HRT, and also how to decide if that's what you want to do, which HRT choice is right for you. So there are 51% of the population are women, and 100% of us will go through menopause. There are roughly about 13 million women going through menopause right now, and 3/4 of those women in the United Kingdom say that the menopause has caused them to change their lives, and more than half say it has negatively impacted them. So it's really, really vital that we have these important conversations and talk about perimenopause and menopause. And more importantly, we support women experiencing them and give them access to the right help. So I hope that this evening we'll be able to do that and provide you with some really valuable, up-to-date, evidence-based information. So we know that about 70 to 80% of women will be affected by menopausal symptoms to some degree or another. And this is due to the fluctuating levels of estrogen and progesterone predominantly, and the drop in estrogen overall. Now, we know that hormone replacement therapy, also known as HRT, is the most effective treatment for relieving menopausal symptoms and improving quality of life. And according to the National Institute of Health and Clinical Excellence, also known as NICE, the NICE guidelines and the British Menopause Society, that HRT involves both the use of estrogen to alleviate symptoms, and there are a vast number of them. We've talked about them previously as physical or psychological and genitourinary or vaginal symptoms of menopause. And these can really vary from brain fog, mood changes, lack of energy, to acne and hair changes, skin changes, changes in our digestive system, changes in our thermoregulatory system, causing us to have hot flushes or night sweats, putting on weight. There's such a vast array. And so we know that HRT or hormone replacement therapy, either as estrogen and progestogen, or sometimes just estrogen on its own if a woman has had her uterus removed, will be able to help in addition to control those symptoms. And we also know that there are really important health benefits to HRT that can help maintain bone health, reducing the risk of things like osteoporosis related fractures. And it's also important in considering our cardiovascular health, our metabolic health. And the way that we can do that is we have to personalize the HRT treatment. So everybody's very unique journey through menopause, and it's really important that we tailor our HRT to the woman and consider things like age, time since menopause, risk factors, and any personal preferences as well. So over the next few slides, I'm going to just guide you through the different treatment options, and some of them you may have heard of, some of them you may be less familiar with, and just to give you a flavour as well of the vast number of different options that there are out there. So this is not a one-time, one thing option of HRT, yes or no, but really sort of a start of a conversation, a journey with your healthcare professional so that we can find the right one that suits you. And often that doesn't happen first time, and it's a process and a journey to go through to find the right fit and the right dose and the right type of HRT for you. So it makes sense to me that symptoms caused by a decline in hormone levels should be treated with a hormonal solution. So as I've said, HRT has two major benefits. One, by replacing the missing hormones, it's easing those physical, psychological, and genital urinary symptoms, thereby drastically improving quality of life for women. And also it helps protect your long-term health. We know that accelerating aging occurs when we have low estrogen levels. It increases our future risk of diseases, osteoporosis, clinical depression, Alzheimer's, diabetes, and also certain cancers. The longer we know that we are in a hormone deficient state, the higher the risk of these long-term health problems, which is why it's even more important for younger women experiencing perimenopause and menopause to be started on HRT early and to stay on it until they're at least 51, which is the average age of menopause in the UK. Now, there are some really key benefits around replacing the hormones in terms of timing, and starting hormone replacement before these disease processes take hold is really important. We know that in the case of dementia and cardiovascular disease and diabetes, that the role of HRT is really in prevention, and for others like osteoporosis and bone thinning and low mood, HRT can be an effective treatment. So we have what is called a window of opportunity, which is within, if we can start hormone replacement therapy within 10 years of a woman going through menopause, which is usually before the age of 60, but not always, it's when you're going to get the majority of the most out of these health benefits. There are still health benefits to starting HRT beyond this window of opportunity. So if you're still experiencing symptoms, it will provide symptom relief and thus improve quality of life. It's no longer about just living longer, it's really about living a healthier life as well. So what does it look like? There are a lot of different options out there, and this is great for women, and really empowering women in being able to choose. You might have heard some of these terms: transdermal hormone replacement therapy. We're talking about patches and gels and sprays, things that are being delivered through the skin. They deliver estrogen directly into the bloodstream. They bypass the liver, which reduces the risk of blood clots and certain side effects. So transdermal HRT is considered the safest form of HRT, unless there's a really good reason. It's really the first line treatment option that we'll talk to you about. Patches, there's a couple of pictures there. I've got some Everell boxes. There are other brands as well, Estroderm, Estradot. They are worn on the skin. We put them below the waist, and you change them twice a week. The gels and the sprays, these are applied daily to areas like the inner or outside of the thighs, or sometimes you can apply them from the shoulder down to the wrist on the outside for the gel. And the Lenzetto spray is quite unique in that it has to be applied on the inner arm, and there are some very specific directions which your prescriber will tell you about if that was something that you were going to be given. And these again are absorbed through the skin. We have what are called intrauterine systems. This is for the progestogen part of HRT. So not for the estrogen, but for progesterone. It's also a reducing as well, but primarily we give progestogen really to protect the endometrial lining from plumping up over time if we just give estrogen on its own. So that's really important to counteract the effects of the estrogen on the endometrial lining. And so we give progesterone in different forms, sometimes in oral forms. We've got a box of Eutrogestrone there, so that's body identical progesterone. We can get it in different tablet forms as well: northisterone, Provera. You may have heard of these types of pills, or you can get it as the intrauterine system, and the one that we use is Mirena coil, and that is quite a clever device because it only needs to be inserted once every 5 years, and it emits a really low level of progestogen because it's exactly where it needs to be right in the uterus there. We also have vaginal creams and pessaries, rings and gels, and these are especially for what we call local estrogen delivery. So they're not being absorbed systemically into the bloodstream, but they're really sat right where they need to act, around the bladder, the urethra, the vagina, the vulva. And these areas are laden with estrogen receptors. And when we lack estrogen in those areas, we get a lot of what we call the genitourinary symptoms of menopause, vaginal dryness, itching, a lack of lubrication. Skin is very fragile, it breaks easily. We can sometimes get soreness and bleeding, feeling like you have to go to the toilet all the time, having more recurring urinary tract infections or bouts of thrush and reduced libido. So vaginal estrogen only options have been really invaluable in that area as well. So the take-home message from here is that there's lots of different options. So if the first type of HRT that you try doesn't suit you for whatever reason, sometimes people can get reactions to certain ones, and there's really no way of knowing this particularly in advance. So I would say all is not lost. Please go back to your prescriber, and there are other options there. As you can see, there's actually a lots of different choice. Here we're talking about, so there are what we call estrogen only options, and there's combined options of hormone replacement. So the combined options mean estrogen and a progestogen together. I say progestogen because sometimes it's body identical progesterone that you might get given as part of your HRT regime, and we can call that progesterone, or it might be a synthetic or what we call man-made form of progesterone, and we call that a progestogen. So these combined patches, the Everel Sequi or the Everel Conti, are combinations of body identical estrogen with a synthetic, low dose synthetic progestogen. You can also get estrogen only patches, Estradard, Estraderm, Everel. These are estrogen only patches. You can get the gel, Estrogel, which is just the estrogen on its own, and then I said the Lenzetto spray before, which is also an estrogen only spray. And their only intrauterine system is progestogen only, and that's the Mirena coil. So there are different combinations of patches and gels, whether you're on whether you need both or whether you just need the estrogen element, and there are different ways that you can sort of pick and mix these options together to find the right combination for you. Now, since transdermal, so that's through the skin, options of estrogen bypass the liver, it does not affect our clotting risk to the same extent as oral options do, which is why we tend to use them first of all. Oral options do exist though, and that's really important because some women are not great absorbers of HRT through the skin. Some majority are, so this is not a common thing that we're seeing, but and actually some women will find that if the gel doesn't absorb well, then the patches do, and vice versa. And so actually we then go to oral options, which are invaluable for women who, regardless of all the different types of transdermal HRT that you might trial, really struggle to absorb it through the skin. And so we will then offer them oral HRT. However, it's really important that when we do that your prescriber discusses with you the risks and benefits, because they're slightly different when you think about oral HRT. We know that it has to travel quite a long way and be broken down by the liver before it's absorbed into the body. So absorption is generally a little bit more erratic than with the transdermal options. It can increase your risk of clotting, and which for most women, if they have a low risk of clotting anyway, then that might not be a big risk to take. But for some women who potentially, if you're a smoker, if you have a high BMI, if you have a history of blood clots for yourself or in your immediate family history, or that you've got certain other medical conditions, that might mean that risk is slightly too much, that we're don't want to take, in which case we need to explore other options. Again, the oral tablets will come just as estrogen only. They'll come just as a progestogen or progesterone only, or they'll come as combined preparations as well. And that's really important for women who have a uterus, that they have both elements to prevent endometrial overgrowth, because if we allow the estrogen to proliferate the endometrial lining too much, then that can lead to endometrial hyperplasia, and that will increase your risk of getting endometrial cancer. And so to get rid of that risk, we give a progestogen as part of your HRT regime if you have not had a total hysterectomy. There you can see I've written continuous combined or sequential combined. These are two phrases as well that you might hear associated with hormone replacement options. And it's talking about whether we're prescribing HRT in the perimenopausal phase or in the postmenopausal phase, and the timing of which we give the progestogen, whether we're trying to mimic menstrual cycles or whether you're no longer having any bleeds at all, in which case we'll give a continuous progesterone along with the estrogen, and that would be considered a continuous combined regime.